You're listening to On the Couch with Dr. Michelle, right here on LA Talk Radio.
Hey everybody, welcome to my couch, as you always are here on Wednesdays now. We're at 12 noon Pacific Standard Time, and in your special area code, in your special part of the world, wherever you're at. Thank you for joining me here. I have one of the best guests I've had, who is an expert on mood disorders, depression in particular, but you are going to learn a lot today because she's covered it all in her latest book. And of course, so many of us are feeling fearful and scared and negative and depressed and anxious with what's going on in the world today and our own health. And of course, they say COVID is no longer a horrible thing, but I mean, actually, they urge us to get, the booster shots and that kind of thing. We're also having strained relationships from everything, arguments. The world is in upheaval, as you know. We also have financial hardships. So it's tough right now for everybody. I was reading some of these statistics in my guest book today, and it said that 1 out of every 4 Americans will experience mental illness in their lifetime, and major depressive disorder is the leading cause of disability in the United States for ages 15 to 44. I mean, that's incredible. And only a fraction of those suffering will seek treatment because, a lot of folks suffer alone in silence. They don't understand what they're dealing with. They don't quite know how to get the help. So my special guest today, let's bring her on, psychologist, Dr. Deborah Serrani. We're going to be talking about her latest book. It is the best. Let me hold it up right now so you can see it. It's got beautiful color too. Oh, I love it.
Thanks, Dr. Michelle. Yeah, they gave me a few colors to pick, and I'm like, yeah, those.
You got it. That's lovely. Dr. Deborah Serrani, Living with Depression, Why Biology and Biography Matter Along the Path to Hope and Healing. Let me tell folks a little bit more about you as well, because, your accolades would take a long time, half an hour, actually. But you're a psychologist, professor, and award-winning author. You're also a go-to media expert on psychological issues. And you've seen her, folks. I know you've seen her before. She's been everywhere on ABC News, the Associated Press, CNN, the New York Times, USA Today, radio programs like NPR, CBS. That's just to name a few. Also, Dr. Serrani worked as a TEDx speaker. She writes for Psychology Today, has worked as a technical advisor for one of the top-rated shows, and has been and still is. It is the Law and Order Special Victims Unit. Y'all have seen that, of course. And she's been a licensed psychologist in practice for over 30 years, as she still resides in New York. Dr. Deborah, you can't be working for 30 years. You look like you're 25. What's up with it?
No, believe me, the outside may look different. The inside is all decrepit and old.
Oh, you're cool. And your book, wow. I mean, it's the fully updated second edition, but it's probably one of the best absolute go-tos books on experiencing depression and other mood disorders, how to cope with them, and the stigma behind them, and how to really get help medically, how to understand what we're all dealing with as well. So, and I say we're all because, I mean, most everyone has depression from time to time in their lives, but, we're going to talk about when does it get pretty chronic to where you should get help. Also, Deborah is going to give you a list, not the whole list, because there's over 450 folks at the end in her Appendix A in her book, who you will recognize. Very high-profile celebrities, geniuses, scientists, art specialists, everybody, authors, you name it. I mean, who have suffered from mood disorders. So with that, with that huge intro, welcome here to the couch. And I also want to thank you in your book for sharing your personal story.
Oh, thank you, Dr.
So,
Michelle. I'm so happy to be here. Thank you for inviting me.
oh, my pleasure. I've been wanting to get you on you're a very busy girl for a long time. So,
As are
so,
you.
oh, can you share with us your story? I mean, it really moved me that you were so transparent and open about your own depression. So, can you touch on that a little bit so
Sure.
everyone can understand?
I did not know at the time that I was struggling with a chronic depression as a girl. I
Yeah.
just thought everybody was tired and weepy and tearful. And I learned this after I was in college and descended into a really very bad depressive
Oh,
episode.
yeah.
And I became very negative in my thinking
Mhm.
and suicidal and acted, had a plan and acted upon it.
Oh,
Luckily, it was interrupted
yes.
and I got immediate help. I
Good.
began seeing a psychologist
Mhm.
and I learned that I was in a depressive episode. But I also learned that I had been living with dysthymic disorder, which we now call persistent depressive disorder.
Right.
And so my therapist changed my life,
Oh, my
saved my life.
oh,
And I said, I want to do this. It was such a meaningful experience that I wanted to become a therapist and help others. And I just noticed along the way that people weren't really talking about their own experiences. I guess there was a lot of taboo about it. But I
yeah.
think it can be one of the most curative pieces when we self disclose in a
Yeah.
way that's treatment productive for patients.
Oh,
So that's why I'm doing what I'm doing.
oh, bless your heart, and again, thanks for being so candid about it, and thank goodness, somebody found you and disrupted your attempt because
Yeah, I'm very, very lucky. Yeah.
yeah, you sure are, and we're gonna talk about that as well because, I mean, it's how we can try to prevent it and how patients themselves
Mm.
can really give themselves, some tools to work with so they can monitor their own depression in that way. So, is that pretty much why you wrote the book? And you just said, "Wow, I got to share how to get better. I'm a psychologist."
I um I had written some academic articles talking about the use of self-disclosure and how it could destigmatize the issue of mental illness with patients. So I was writing from a very, I guess, clinical and academic point of view. And somebody had suggested that maybe there was a self help book
Mm,
in this idea. And so I did. I started to write Living with Depression, sort of like part memoir, part self help book,
mhm,
because there are so many things that I understand uniquely as a
right.
patient who struggles with depression and
Sure.
as a doctor who treats depression. And
Yes.
I think so
Absolutely.
much of the general public isn't aware of some of these tips and tricks
Mhm.
and things to do with insurance or things to do with struggles with pharmacy and other types of care. So that's where this was born from, like a collective effort to say, let me see if I can, take my story and help others.
Oh, that's beautiful. And you sure have. And the book is really thorough, explaining so much about the symptomology and medications and treatments psychologically, with therapists. And so we're going to get into some of that stuff. You talked about, the idea of stigma. And,
Mhm.
um, there's also a lot of cultures. And I know you work with folks from all over the world and cultures um, that pretty much do place shame or stigma on any kind
Yeah,
of depression or bipolar or any kind of
yeah, yeah.
person. Gosh, I mean, this is all over the place.
Yeah, and you'd think, Dr. Michelle, that with all of the neuroscience and studies that we have that show that a great deal of mental health issues are definitely genetically related, environmentally related, that we see the neuroscience
Yes.
behind how certain disorders, particularly like depression,
Mhm,
impair the frontal lobe of the brain.
mhm.
And yet there's still this
Yes.
stigma because I suppose, we still sensationalize mental illness. Look, we just had
Sure.
Halloween, and we know what kinds of
Oh,
costumes can kind of get a little destigmatizing. I mean, stigmatizing
sure.
with the holiday. But yeah, there are many cultures that don't embrace
Mm.
let's talk about things. Let's address certain vulnerabilities. It's seen as weakness, or it's seen as just too much, navel gazing. This really isn't important.
Right, right.
So yeah, it can be very, very challenging.
Sure. I mean, how many times have you heard patients tell you, "Oh, I don't tell any members of my family that I have a therapist.
Right, right,
Oh,
right.
no one knows. Oh, no, 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 that would never happen. I'd be shamed." And
That's true.
terrible.
That's true.
It's sad, but I'm not blaming the culture or, it's just it's a thing, but
Yeah, I think, if we saw somebody with a broken leg or a broken arm, we would say, "Oh, you have to go to the doctor for that. Of course, of course. In fact, I'll help open the door for you as you go."
yeah.
But
No,
the invisibility of many kinds of chronic illnesses besides mental illness, there's just this either it's denial, avoidance, or minimization that happens.
mhm,
But those of us who live with
mhm.
mental health issues will tell you that it doesn't define us, but it certainly is a part of us that we have to be mindful of and take care of.
Exactly, and also you educate people so much in your book, about, the inheritance, factor. I mean, I'm sure you've heard a lot of, patients say something like, "Well, we didn't know quite what's going on, but my grandmother seemed to be pretty down all the time," or "My
Yeah,
grandma," or, "My dad was a pretty quiet guy, and he just didn't say
right. Yeah,
much. He would go
yeah.
withdraw, and he didn't wanna be with the family," but we don't know really what the deal was, but I'm depressed all so do you have any advice for people to sort of look into their family background or you
Well,
know
as you know, Dr. Michelle, it's such an important thing to be able to glance at your family history, not only for your medical history and the lineage that's there, but also
sure.
for your mental history. We know that a large percent of certain disorders carry with it a genetic predisposition, but the switch that turns on those genetic predispositions don't guarantee that
Right.
if there's a lineage of depression or mood disorders or OCD anxiety, that you're going to get
Sure.
it. But
Sure.
but it can help us understand
Yeah.
why you may be struggling with it.
Yeah.
And what we know about epigenetic studies are that,
Mhm.
which is really not a lot, but what we know is that certain types of traumas can flip these switches for some people.
Boy, they
And
sure
so
can.
that's why if you have difficulties in early childhood or situational issue going on, like the
Mhm.
loss of a job,
Mhm.
you may fall into a depressive disorder because of those traumas and the environment pressing on your genetics. So
Wow.
it's a biography, biology kind of nature nurture
Mhm.
experience. And the more you know, the less shame you feel.
No, it's really true. Like Goodwill Hunting. I was watching that the other day, and it was like, "That's not your fault," Robin Williams.
Yeah, it's not
You
your
know, you
fault. That's so true.
you grew up in this crazy traumatic environment, and also, by the way, your mom had super depression, so there you
Sure.
go, bada boom, you're 50-50 right there, so you're,
Right, right.
so excuse yourself and stop beating yourself up for having for not
Right.
feeling as positive.
Right. We would never shame somebody for having a medical condition like cancer, leukemia, multiple sclerosis, even though they may have a lineage of that. But
Well, right.
somehow we carry that,
Mhm.
shame stick, like, well, you're not trying hard enough, or you're just, oh, you're too sensitive, you're too dramatic.
Yeah, and
Uh,
you're right, and it is. It's a stigma, and it's self-shaming, and, "Oh, I shouldn't be," and, no,
mhm,
you're
mhm.
right. It's like on the other hand, there are those celebrities and people in the media and, very high profile people that you list in your Appendix A,
Mm.
right? Oops, I'm trying to get the glitter off. There you go, folks. You list in Appendix A who, over 400, probably around 450 maybe sort of kind of people who have been diagnosed with a depressive disorder, primarily depression, major depressive disorder, and bipolar
Right.
disorder.
I wanted to cover mood disorders,
Yeah,
particularly in postpartum.
yeah, yeah.
And
Postpartum is huge, and you specialize that in that as well.
yeah, and I experienced that as well, which is a very common thing when you have a depressive disorder pre before you start to decide to have a baby. If you're struggling with a mood disorder, bipolar or unipolar, it's a good idea to kind of review that because there's a high likelihood
Mhm.
after the trigger and trauma of birth that
Right.
you may fall into postpartum. And it's not just postpartum depression. There's postpartum bipolar, postpartum OCD. It's the actual disorder with a peripartum onset.
Mhm. And, again, there's dual factors in creating that. There's, the hormones, of course,
Sure.
huge, and the loss of or change in hormones and the loss of the connection with that little being that's,
Yeah.
only women who've had kids can relate to this.
Sure.
Little,
And
yeah.
fathers can get postpartum too.
Yes, they
And
can.
that's an unusual thing to think about, but it's really
Right.
just a trigger being a new parent after the birth of a child. So, specifying different types of onsets is helpful for people too, like a seasonal onset of depression. So
Right.
all this education is really great. So you can say, gee, there is a reason why I'm feeling this way, and these are the things that I can do about it.
Oh, that's super. What are the most common kind of differences between, say, a major depressive disorder or just a, you know, depressive disorder in general and bipolar disorders? So people will understand this better.
Well, the best way that I could describe that is that a major depressive episode, or what used to be called a dysthymic, and what's now persistent depressive disorder, the experience of emotions kind of falls in one polarity. It
Mhm.
pulls
Mhm.
down to this sadness, despair, and depression.
Yeah.
And
Yeah.
individuals who struggle with those unipolar disorders, and there are quite a
Mhm.
few,
Mhm.
kind of move from that to back to normal kind of
Mhm.
state.
Mhm.
People who have persistent depressive disorder, it's a longer, more timely chronic experience. And a
Right.
major depressive disorder, which most people in the general public see it, that's
Mhm.
really a somewhat of a unusual dip
Mhm.
that
Yeah.
can last a week, 2, 3, or a few months, and then the person comes back.
Right.
When we
Right.
talk about bipolarity, we're talking not only about this dip
Yes.
where depression is, but an elevated state that
Mhm.
kind of comes up to an expansive level of hypomania or mania. And
Mhm.
somebody who has that kind of
Mhm.
cycles back up and down
Mhm.
throughout the calendar year,
Sure.
uniquely to them, because everybody experiences this differently.
Sure.
So they're two very, very different experiences, but both can be extremely disruptive in the quality of one's life.
Oh my goodness, you're right. And the hypomania or the manic episodes are, come in all different forms. And it's very, very difficult to manage and very scary, you
Right,
know.
and sometimes people don't know they have it because they feel so good in a manic episode, or a hypomanic episode
Mhm.
is not as observable, it's not as,
Yeah.
expansive, so
Mhm.
sometimes people will say, "Well, what do you mean I have bipolar disorder?" That's
Mhm.
called bipolar II disorder,
Mhm.
so,
Mhm.
when you have some of these experiences and you're not sure, this is why
Mhm.
it's so important to go to, like a trained mental health person who can help you understand what it is that you're living with. Is it situational? Is it chronic? Is it subclinical?
Yeah.
Is it a true disorder that needs to be addressed?
Sure.
There could be all different kinds of things.
Gosh, it's so true. Um, and a lot of people, are, oh, big pharma and, medication is maybe not the best. And let's start using, herbal products and this and that. But I'll tell you, from working in hospitals and psychiatric facilities for a while, those antidepressants and some of the they call it antipsychotics or whatever, um, they really are helpful to people. They really are. So
It's
maybe you can explain that and dissolve some of that fear around it.
Dr. Michelle, that's it is a tough subject, but we do see it when we're working on the front lines, particularly mild cases of depression
Mhm,
can do well with these holistic approaches,
mhm,
alternative approaches, um, aromatherapy, light therapy, those kinds of things that we call complementary treatments. And
right.
there's great science in it, without a doubt.
Sure.
But
Right.
if you're struggling with a moderate or severe mood disorder,
Mhm,
it's unlikely that those holistic, non-traditional methods are going to really provide the necessary changes and shifts in your neurochemistry. Talk
right.
therapy, which we do,
Mhm,
um, does address problem-solving coping strategies and getting to certain
mhm,
um, blind spot issues or trauma that we haven't
right.
addressed. But
Sure,
sometimes medication really is needed because the
sure.
depressive state is not just an emotional experience, it can be a physical one.
Right.
And there's significant brain changes. You're not functioning as well as you could. And I remember this with
Do
when I
you?
was 19 and I just
Oh,
was so focused on ending my life and this is what it
oh,
has to be and I'm going
yeah.
to feel better with this. And I didn't realize how like damaged my thinking was until
Sure.
I recovered, and how could I ever have thought that? My God, I
Right.
can't believe I ever felt those things, and it's so alien and foreign to me now
Right.
because I'm healed. And
Yes.
I take medicine. I've been on medication for 30 years,
Sure.
and, I've come off it from time to time just to see,
Mhm.
and I'm one of those individuals that, "Hello, nice to see you again, little black cloud, okay, let me go back on it." And
Sure.
just like I wear my glasses, or if I needed insulin, or if I needed something else to, regulate my body, I take my
Exactly.
medication, and
Mhm.
it makes me better. It doesn't change me, it makes me a better Debbie.
Yes, absolutely. I mean, and that's the thing I think we both stress, and I know so many of my colleagues do. It's like if you have diabetes, you need your insulin.
Right?
Same. If you have, and I was going to ask you about that to help explain a little bit, but you got to push along your own serotonin level a little bit.
Yeah. Yeah. And, I have family members, and we do have a lot of mood disorders and anxiety disorders in the family lineage.
Mhm,
But I know for myself as a doctor
mhm.
that my best self is when I follow my treatment plans and,
Ah, yes.
I do my self-care and I
Mhm,
take my medication consistently.
mhm.
And I know as a patient that when I don't do those things, I'm
Right.
not at my best, and, that affects I couldn't do the work that I do, and that would affect so many other aspects of my life. But
Yeah.
there's still a lot of shame about medication and the need for medication, like, you could just
Mhm.
will it, "I'm just gonna snap out of it,"
Right. Right.
but you can't do that. You can't will my brown eyes to be blue. I can't do that.
Right.
Um,
Exactly.
so I know it's a controversial
Mhm.
subject, and that's
Yeah.
why I talk openly about it because
Mhm.
there's a lot to consider and a lot to bargain with. But
Right.
to not be alone in saying, okay, I need this medication because my body just doesn't function as well and my
Mhm.
mind doesn't function as well.
Mhm.
So what? So be it.
So what? It's just whatever's going to help you, and the majority of folks who I've worked with, they have seen really positive improvements.
There
By
there are certainly stories out there when people have, maybe medications that don't work well or adverse side effects, but I agree with you, Dr. Michelle. I
Mhm.
would say 99.9% of the people I work with will say, "So why didn't you suggest this sooner?" Or "Why didn't I start this sooner?" For me, it was
Exactly.
life-changing. It was really, truly
Right.
life-changing.
It's good for you. Bless your heart. I thank you for sharing that again. And by the way, Dr. Deborah Serrani is the author of the second edition, updated edition of her best-selling book. It's Living with Depression: Why Biology and Biography Matter, along with the Path to Hope and Healing.
Yeah,
And
such a
it is
mouthful, that second title.
it's a mouthful, but you know what? We got to have that subtitle there because it really does. It's what it's all about here in your book.
Oh, that was my editor. I'm like, really? Does it have to be that wordy? Yes, we
Right.
like it. Okay.
Folks really know what's going on here, you know. So there it is. Whoop, there you go, folks. Excellent book. It's like an encyclopedia, actually. It tells you so much about, you know, different types of mood disorders, including, you know, major depressive, persistent depressive. Also, we have the bipolar disorders, other mood disorders as well are explained in there. You know, a lot of people say to me, I'm anxious part of the time as well as being depressed. Do they usually go hand in hand?
You know, the interesting thing about mental health issues is that the rule of thumb is there's often a comorbidity or a coexistence
Mhm.
with a disorder. So yes, depression likes to join itself with anxiety, and anxiety likes to pal around with depression. So
Yeah,
it's not unusual to have these dual different kinds of experiences. But this is why each person has to really be working with, if you're working with your primary care to figure out,
Mm.
what some of your initial symptoms are,
right,
and they recommend a therapist, that you go to somebody who
yeah,
specializes in what you're experiencing.
right,
So for instance, if somebody's going to come in and talk about an eating disorder or addiction,
right,
I'm not that person.
right.
And it's best to go to that kind of trained specialty because they
Mhm.
know the current evidence-based things and treatments and things like
Right.
that.
Really,
But having a targeted diagnosis really helps.
sure.
And there's a lot of great things online. I know some of my own colleagues are like, "Oh, you don't mind when people do those self-tests." And I'm like, "No, not at all." It kind of is like a shorthand. They
Right,
know they're depressed, or they know they're struggling with OCD because they took the OCD test from UCLA online. So
right,
those
exactly.
things can really be useful tools.
Right. And then
So yes, there's a lot of coexistence or comorbidity, sometimes more than two, sometimes three or four.
sure.
So the more you know about what your unique experience is, the more targeted your treatment can be with the therapist
Yes.
that you work with.
Oh, that's so true. Beautifully said. And speaking about working with therapists, um, can you talk about some of the really most effective sort of types of therapies for depression and
Sure.
other mood disorders? Mhm.
Um, I'm a trained psychoanalyst,
Oh, love.
and
Very cool.
psychoanalysis, yeah, I just love it. Psychoanalysis is a very, very old therapy, and the art of it kind of looks towards subconscious or trauma related issues.
Right.
And it can be very, very helpful for individuals who come from a long narrative of early abuse and things of that nature.
Sure. Sure.
But a lot of science-based research also suggests cognitive behavioral therapy. This
Mhm.
is where you look at how you're thinking, because many people who do experience depression have a very negative outlook. It's not that they're doing it on purpose. Again, part of the frontal lobe of the brain just
Right.
isn't using reasoning, judgment, and problem solving to its effective level.
Yes.
So we look to change certain kinds of thinking. Instead of being catastrophic or negative, try to say, okay, I'm out of a job. This is terrible. How am I going to make my rent? Well, I always bounce back on my feet and I will find something. And if not, I can ask for help and I'll get help from my family.
Right.
So it
Exactly.
takes
Yeah.
the emotional piece of saying I'm doomed to, well, it is bad, and frames it in a
Mm.
reality that hopefully has some positive pieces to it. And then there's a behavioral
Right.
strategy which looks at the way you've shaped your behavior, the reinforcers that um, attend your life in a particular way might be reinforcing you to be sad. And so a
Right.
behaviorist would look to shift and
Right.
start finding ways that you reward yourself positively for
Yes.
more uplifting things.
Right. What
Um,
it might be, whatever, you know,
mm,
meditation or getting social or getting more social. Yeah.
right. You know, and we all kind of know a person who tends to love, always, they kind of get reinforced because their friends rally around them when something terrible
Right.
happens.
Right.
That's not necessarily a depressive disorder, but it can
Right.
contribute, especially if you're looking at the glass half empty.
Right.
And then there are lots of wonderfully uh, short-term therapies
Mhm. Mhm.
that look at like 6 to 12 weeks interpersonal therapy techniques. So the key here is that there's lots of different things. There's EMDR, there's
Yes.
tapping therapies. There's
Right.
so much that one can look at. And I think
Right.
you don't necessarily have to read my book, but if you
Right.
do a little deep dive on what therapies are out there
Mhm.
and you just research them and read a little bit, a sentence or two,
Mhm.
they'll speak to you and what you may
Right.
like more.
It's really
So there are, people who work with me, um, are know they're coming in to do insight work.
sure. Exactly.
And you might not really want to do that. Maybe you want to say, I want to do cognitive behavioral, or wait, what
Sure.
is that EMDR? I'm going to do that.
Right. Right. And the EMDR is the eye desensitization.
Right. Eye movement desensitization reprocessing,
Um,
which is a fascinating,
yes.
wonderfully science based. I've seen it. I've took training in it.
Yes.
It's remarkable in what it can do.
It is.
Very neuroscience based. And
Mhm.
again, I love to embrace all different interventions and treatments. There's
Sure.
a lot of room for us all as clinicians to
Right.
help people we're working with. It's
That's
just a
true.
matter of you, whoever's struggling, to find
Mm.
the clinician that best suits and makes them feel comfortable.
Exactly. Whatever, and who you vibe with or who you connect with, and also the treatment that really feels
Right,
for
right,
you. If you're moving along and feeling better and better, and
right.
it's not always fun all the time to have psychoanalytic or the other exploratory therapy
Yeah,
techniques, because it can be painful and difficult, because that's why we
absolutely
have
true.
all that junk down, right, Dr. Deborah?
Right, that's so true. And look, I do think there's more than one road to Rome. Is that the expression?
Yeah.
It's about individuals knowing, what they want, and you'll know if you're in therapy if you're feeling better, and if you're not, it may just not be a good match. And to
Right.
give it another shot because hope and healing is out there.
Yes, it is. And there's, again, there's, and read up. I would encourage, viewers and listeners to read up on the different types of therapy, so you'll understand what they may be and how they may be best for you. And like
Right.
you said, Dr. Deborah Serrani, it's okay to go online and check.
Oh my gosh, I love the internet for that reason. In fact, I'm always telling people,
Yeah,
read this, read that, or did you see this?
yeah, yeah, exactly. So the medical treatments are good as well. Explore some of those. Doctors have, don't let the names of certain medications freak you out, or
Yeah,
medications,
the
right?
the the one thing that I would like to say,
Mhm.
to listeners is, medication can be a very, very helpful way
Yes.
to ease the symptoms of serious depressive disorders,
Mhm.
and there are genetic tests now. I'm not affiliated with any of these labs, though I wish I was.
Isn't that
Um,
incredible? Yeah.
it's incredible. I actually took the test to see if what I was taking was
Mhm.
accurate, and it is.
Great.
So we can find very targeted, immediate medications through genetic testings that you get through your medical doctor to assess what type of medicines will help address your particular genetic issues with your depression. And that's the most traditional
Mhm.
first line is looking at medication to help serious depressive illnesses. There are many other
Mhm.
kinds of medical interventions. There's electroconvulsive therapy, which is not
Oh, yeah.
like the movies show, not
No.
like Beautiful Mind or One Flew Over the Cuckoo's Nest. It's done in a hospital setting, and you're put under a sedative, and certain electro areas of the brain are stimulated, and it really helps people who struggle with severe treatment resistant depression.
Sure.
Um, and then another more common accessed intervention is called RTMS, transcranial magnetic stimulation.
Mhm.
And there's no side effects. And you can go to a local clinician's office,
Right.
and they do this electromagnetic kind of swirly stuff around,
Right.
and it stimulates the areas that are not functioning as well, because that's what we know about brain function and depression. There's less
Yes.
electroactivity.
Yes. Yes.
And then there's even more.
Yeah.
There's deep brain stimulation. There's vagus nerve implants. If you have a treatment-resistant depression, there's a lot of which once were experimental therapies now available.
Yeah.
But most individuals, about 40%, and that's a low number,
Mhm.
40% of us do well with medication.
Mhm.
The other 60% may need to kind of look at these
Sure.
alternative approaches.
Sure, exactly, and you know as well that for persistent and more serious diagnoses of depression or bipolar depression, they really have had some amazing results.
Yes.
With yeah, with the RTMS as well. I mean, I've heard a
Mhm.
lot of positive things about that, and the deep brain stimulation as well. It's
They're even
happening
they're even
fast.
talking about using psychedelics, and
Yes. Oh, that's.
you
Mhm.
know, there it's wonderful to be broadening the scope of seeing
Mhm.
what can help certain individuals, because for a
Mhm.
very long time there were patients who felt that nobody was really believing them, that their depressions
Sure.
were
Right.
intractable and they wouldn't get better, and oh, you're just not trying hard enough and you're not following through on your treatment. But these
Mhm.
are real significant possibilities that
Yes.
can offer relief for individuals, which is really a wonderful thing,
Right.
to
It really.
know that they're being heard and treatment and research is happening.
And they are giving the certain medications, like ketamine treatments.
Yes. Oh, I forgot to talk about ketamine. Yeah, and esketamine, and yeah, there's a whole branch of psychiatry and medicine, botanicals, all kinds of things. And it's, to me, as a doctor and a patient, it's exciting to see that there's more than just the traditional things out there, because they don't always work for everybody.
No, it's really true. What you talk about the 5 R's. I
Oh, I
was
have to get my book for that.
Yeah, girl, let's go take a look.
Yes, I do talk about the 5 Rs, and I've
And,
written about the 5 Rs, but do I remember the 5 Rs?
oh, of course
No.
you do. The moment you open the page, you're gonna say, "Oh, yeah, that's right." But
Yeah, it's relapse, recovery, remission.
there you go.
Yeah, oh, okay, I found it. That's so funny. I'm glad people can see a real moment here. Um,
It's all real. It's all real,
when
Deborah.
when you're somebody who lives with depression, you just think you go to the clinician or you go to the
Right,
doctor and you're just going to feel better.
right.
And I thought it would be really helpful to talk about the levels that occur along the way. So when you're looking to totally be feeling better, which might be 6 weeks away, six
Yeah,
months away, depending on what you're struggling with, these
right.
little steps help you go, oh, I will get to the top of Mount Everest, because every step counts.
Right.
So the first one, and you let me know if I'm talking too long.
Oh,
The
no,
first
no, I love this.
the
This is.
first one's called response.
Mhm.
And this is when you are just beginning to feel a little bit better. And
Yep.
we call that a response to treatment. And that's the first level. And then we hopefully want you to keep doing your therapy, taking your meds, doing your treatment goals. So you reach a level of remission, which means your symptoms are gone.
Right.
Once you reach
Right.
remission, our next goal is to hopefully get you to recovery, which means that you've been a whole year, 9 months to a year without any symptoms. So
Right.
these are the big 3 steps that happen. But
Mhm.
if and this is one of the toughest things to talk about,
Yeah.
the
Yeah.
one thing that prevents people from feeling better and getting better is
Yeah.
consistency. The research shows that if we don't consistently take our meds, consistently do our self-care, consistently work our schedule, eat well, sleep well, all those things,
Yes.
we're going to fall into what's called relapse.
Yep.
That's the next R.
Yep.
Or recurrence. You have a recurrence of your symptoms.
Yep. Yep.
So I just thought that it would be, and it just so happened to all be ours.
Yeah.
That it just would be,
No, it's true.
that it would just be helpful to
It's your
understand these steps and
Sure.
how, not only giving them a name, but understanding that we really can get better over the course of time if we do these things.
No, it's really true. Well said and beautifully put. And that's the thing. And what I hear a lot is folks say, I'm feeling so much better. I don't know if I really need this.
Oh, yes, and that's what happens.
And the cold turkey is not good either with the SSRIs, or of course.
No. Yeah, terrible. And Dr. Michelle, that's such a good point, because when we get to remission,
Yeah.
we think we're there, but we
Right.
haven't gotten to recovery.
Right.
And so that's when people abandon therapy, or they don't take their meds, or they say, I'm going to come every other week or once a month.
Right.
And we say, we still need to have this consistency. And
Sure.
that's the reason why, because you need to get to recovery. And
Right.
that's a bit of a longer journey.
Exactly. And there's always, again, as we talked about, stigma, and there's pressure from others around us, we feel, am I anti-pharma, that whole thing is like, am I ever going to be able to get off these medication? When can I get off? When am I going to be able to just it's like, well, you may not ever.
Right. You may not.
And
And that's okay. And that's okay too. How do we make that okay?
Yes, exactly. It's really okay. And as you said, it's just like having, an issue. You have to take your medication. You need your
I
glasses.
need my glasses. I'm not getting LASIX. I'm too chicken for that. But
Don't
I
trust
would still need my reading glasses, because they don't fix that.
right.
But yeah, how do we make things a little easier for people to bear, whatever their vulnerabilities may be? It doesn't define us. It's just a part of us.
Yeah. Yeah. I just wanted to touch also the 2B factor in depression. You talk about that. It's the
Right. That's the biography part and the biology part. Think of nature, nurture.
Okay.
Really know and try to know your genetic makeup, your family background. And then, this is the psychoanalyst in me, really understand your life narrative, understand what you've been through, where you've lived,
Right.
what strengths you have, what weaknesses you have, what things were hard for you, what things maybe were traumatic that you didn't realize were.
Yeah.
So really know thyself. And the more you know, and the partnership you have with your therapist,
Sure.
it becomes a really meaningful journey to say, okay, this is who I am, this is who I've been, and this is who I want to be.
Yeah, beautifully said, Deborah. In case you just tuned in here, you're on the couch with me, Michelle Cohen. My special guest is Dr. Deborah Serrani. She's written an amazing book, Living with Depression. Ooh, and there's my glare. Pick it up. It's one of the best books I've read, folks.
Dr. Michelle, you're so nice.
Oh, it's true,
Yes,
Deborah.
so nice.
Dr. Serrani, you're why biology and biography matter along the path to hope and healing. It's really important for you all to understand how important all this stuff is. The clouds do clear. There is wonderful hope with all the medications and the therapies that we have today. to manage depression.
Mhm.
So, briefly, I was really shocked to learn the statistics, going back earlier to what I said, and I was reading in your book, the second leading cause of death for adults, 25 to 34, is depression.
Yeah.
Oh my God. And then the third leading cause is for adolescents, 15 to 24. Why do you suppose this is, Doctor?
Well, I think a lot of it has to do with certain cultural issues, certain pressures in life.
Yeah.
We know that the adolescent brain doesn't fully develop till age 25. And sometimes the pressures of things and children who can't really manage and problem solve,
Right.
suicide is the most preventable death.
Yes.
And the highest level of suicide rates are for older men,
Yes.
45 to 80. It's a big
Yes.
age range.
Yes.
And that was surprising for me to
Yes.
discover. But yeah, suicide rates are higher than before. We thought they would get a little bit lower during COVID, and
Right.
they did, but not really.
Mm-hmm.
So, what I can say about suicide is that a large percent of individuals who die by suicide have had
Mm-hmm.
an undiagnosed depressive disorder or an undertreated
Mm-hmm.
depressive disorder.
Right.
So this is why, we want to screen kids young. We want to educate everybody about the signs and symptoms, and we want to get help because
Right.
there is hope.
There is, beautifully said. And to your point too about older men, I mean, I really get it. I mean, there's so many factors, a lot of retirement perhaps going on, a lot of children in the house, they're older and they're out and away to college, or they have their own families.
Mhm.
The stressors involved financially.
Sure. Yeah.
And there's ageism in the workplace. A lot
Very
of,
much so. Yes.
so many different factors. And, I'm getting older. I have, more aches and pains, and how I have
Right.
diabetes, or now, I mean, I really get it.
Oh, yeah, this isn't what I thought it would be. And
Exactly.
what do you mean? This is my last lap around,
Right.
Yeah.
My golden years were supposed to be golden.
Yeah.
So, I mean, it's true. But anyway, I just wanted to wrap by saying thank you so much again for this book. You're amazing.
Oh,
And
that's so kind of you. And you are too, and all that you do in outreach, and just having this show to, being on the couch with you has been a wonderful experience. So thank you.
oh, thank you so much. Dr. Deborah Serrani, everywhere. And you can also check her out, Dr. Deborah Serrani, and that's DRDEBORAH. That's the proper way to spell it. Dr. Deborah Serrani, SERANI.com. That's her website. Find out more about Dr. Deborah and all of the wonderful things that you have to offer. And check her out. You've seen her before in so many different media outlets. And this is her latest book. If you'd like to get a hold of it, it is everywhere. And it will really help you understand. Look, if you're not dealing with depression, if you don't have a diagnosis, or you're just wondering why you're not feeling well, also, you can help family members by giving them this book. Have a wonderful week. Thank you so much for being here.
Thank you so much. You take care.
All right. Bye-bye. Thanks, everybody, for being here on the couch. And this is Dr. Michelle. I'll be back next week with another great author. We'll be talking about other things to help you out. Have a great week. Bye.
You're listening to On the Couch with Dr. Michelle, right here on LA Talk Radio.